Welcome back to the Deep Dive. We are really glad you're here with us today because we are tackling a monster.
A literal monster?
Yeah, and I do not use that word lightly. We are looking at a topic that keeps nursing students up at night, keeps public health officials awake, and, frankly, is the stuff of Hollywood disaster movies.
It is the stuff of nightmares, both academically and literally. We are diving deep into Chapter 11 today.
Chapter 11, Environmental Emergencies and Bioterrorism. Now, for the learner listening to this, whether you're prepping for the NCLEX, the ATI, or just trying to survive your N242 MedCert rotation, this is a pivotal unit. It is high stakes.
It is, and it's a very specific kind of high stakes. In the emergency room, we talk about high acuity, low frequency events.
Right.
These are the things you might not see for 5 years, but when you do see them, if you don't know exactly what to do in the first 5 minutes, the consequences are catastrophic. People die.
No pressure, right? Just a casual Tuesday in the ER.
Right. No pressure at all. But that is exactly why the exams, the NCLEX and the ATI, they love these topics. They want to know if you can spot the needle in the haystack.
So, to help you navigate this minefield, we have pulled together a very specific stack of sources. We aren't just, reading a textbook here.
No, the textbook is just the baseline.
Exactly. We have a set of Chapter 11 objectives, which acts as our official roadmap, the syllabus, essentially.
Yeah.
But more importantly, we have a student PowerPoint presentation titled Emergency plus Student plus PPT.
And this is the gem. This is the secret weapon for anyone taking these exams.
It really is. It is not just the clean, pristine slides provided by a publisher. This thing is battered. It's covered in handwritten notes, scribbles, circles, arrows. It's like finding a map that someone else has already used to escape a maze.
Those notes are critical. They bridge the gap between what the book says and what the test actually asks. When a student circles a word 3 times or writes TNOW this in all caps, that is a direct signal from the instructor about where the points are on the board exam.
Exactly. We are going to decode those scribbles. Our mission today is to move through these environmental threats, so heat and cold, and then into the terrifying world of bioterrorism with anthrax and smallpox. We need to extract not just the facts, but the logic, the why behind the triage.
Because the NCLEX does not test your ability to memorize a list. It tests your ability to make a judgment call when 2 really bad things are happening at once. It tests your safety radar.
So let's start with the environment. Source number 1 is the objectives list. It starts with heat-related illnesses. And interestingly, the very first bullet point is not about treating a patient, it's health promotion and maintenance.
I love that you pointed that out first. It is so easy to skip.
Yeah, you just gloss right over it.
You do. You want to get to the drama, the IV fluids, the ice packs, the chaos. But in the nursing world, and specifically on the exam, health promotion is a massive category.
Why is that? It feels a bit, soft. Like drink water, wear a hat. It feels like common sense.
It feels soft until you realize that preventing the emergency is the absolute most efficient form of medicine. If you get a question on the exam about a community health nurse speaking to a high school football team or a group of construction workers, the answer is not about starting an IV. It's about scheduling. It's about acclimatization.
So the health promotion objective is signaling us to look for preventative strategies.
Correct. It's asking, do you know who is at risk? The elderly with poor thermoregulation, the athlete pushing too hard in August, the worker on diuretics who is losing fluid before they even start sweating. And do you know how to teach them to avoid the ER in the first place? That is priority number 1.
It makes sense. The best nurse is the one who keeps you out of the hospital. But let's say the prevention fails. We move down the list. Item number 2 is heat exhaustion. Item number 3 is heat stroke. They are listed completely separately.
And that separation is the entire ballgame.
Explain that. Why does the list separate them if they are both essentially just getting too hot?
Well, if the source lumps them together, it implies a spectrum where the treatment is the same. But by listing them as 2 distinct items, the source is telling us there's a line in the sand. There is a physiological pivot point where exhaustion becomes stroke.
And we need to be able to spot that exact moment on a test question.
You have to. Let's look at heat exhaustion first. Think about the physiology. You are hot. Your body wants to cool down. What does it do?
It sweats. That's the body's AC unit.
Profusely. And your heart rate goes up to pump blood to the skin to release that heat. So the clinical picture of heat exhaustion is a patient who is wet, clammy, pale, tachycardic, maybe a little nauseous. But, and this is key, their body is still fighting. The mechanisms are working.
They are compensating, they are stressed, but the machine is still running.
Exactly. They are in the fight. Now, Cross the line to item 3, which is heat stroke. What happens there?
The system crashes.
Total failure. The hypothalamus, which is your internal thermostat up in the brain, essentially burns out. It quits, so the sweating stops.
And that's the red flag. That's the siren.
That is the siren. If you see a patient who has been in the sun and their skin is hot, dry, and red, that is a medical emergency of the highest order. They are not sweating because they can't anymore. Their cooling system has been destroyed.
It's totally counterintuitive
Right.
because you expect a really hot person to be sweaty. But the dry skin is the sign of death knocking on the door.
Anhidrosis. That's the lack of sweat. That is the technical term you might see on the ATI or NCLEX. But the other big differentiator is the brain. In exhaustion, you might be dizzy or have a headache. In heat stroke, you have altered mental status, confusion, delirium, seizures, coma.
So if I'm reading a case study and the patient is arguing with me or doesn't know what year it is or thinks they're at a birthday party when they're actually on a hot roof,
You are in heat stroke territory. You are no longer giving them Gatorade and having them sit in the shade. You are calling a code, you are establishing an airway, and you are cooling them aggressively. Ice packs to the axilla and groin, cooling blankets, peritoneal lavage if it's bad enough.
that distinction, compensating, which is exhaustion, versus failing, which is stroke, seems to be the core concept for this entire section.
It is. The intervention has to match the acuity. Education and hydration for the first. Rapid medical management for the second. If you treat a stroke patient like an exhaustion patient,
Yeah.
just giving them a drink, they will die. That's why the exam tests this over and over.
Now, the objectives list flips the thermometer. We go to cold-related injuries. And the structure is identical. Health promotion first, then hypothermia, then frostbite.
Same logic on promotion. Don't go hiking in jeans in December because cotton gets wet and freezes. Layering. Covering exposed skin. Nutrition, because you need calories to burn for heat.
Look at the hierarchy between hypothermia and frostbite. Hypothermia is listed as number 2. Frostbite is number 3.
What do you think that is?
Well, going back to the triage concept we just talked about, hypothermia is the whole body. Frostbite is just a part of the body.
Precisely. Systemic versus localized. Hypothermia is a drop in your core body temperature. If your core drops below 95 degrees Fahrenheit or 35 Celsius, your heart muscle gets irritable, you get dysrhythmias, your metabolism slows down, you can die from cardiac arrest.
Whereas frostbite,
Frostbite is tissue freezing. Ice crystals literally form in the cells of your fingers, toes, nose. It causes necrosis. It's painful. It can lead to gangrene. You might lose a toe, but a frozen toe will not stop your heart.
so if a patient comes in, and I'm imagining the classic stranded skier scenario, and they have black frozen fingers, but they're also shivering violently and slurring their speech,
Endure the fingers.
that is hard to do. I mean, the fingers look terrible. They are visually arresting.
It is incredibly hard. Visually, the frostbite is what grabs your attention. It looks like a horror movie, but you have to treat the hypothermia first. You have to warm the core. Because if you start warming the fingers while the heart is still cold, you aren't saving the patient.
Can you explain that? Why not do both at the same time?
You can try, but the absolute priority is the core. There is a concept called rewarming shock or afterdrop. If you warm the extremities too fast, the blood vessels in the arms and legs dilate.
Okay, I'm following.
Those vessels are full of cold, stagnant, lactic acid-filled blood. If you dilate them, that cold, toxic blood rushes back to the core, to the heart. It drops the core temperature even further, that's the afterdrop, and can send the heart into a fatal arrhythmia like VFib.
Wow. So you can literally kill them by treating the frostbite first.
Yes. Life over limb, that is the mantra. The objectives list puts hypothermia first because it kills you first.
That is a crucial takeaway for the exam. Don't get distracted by the black toe. Look at the thermometer. Monitor the heart rhythm.
Exactly, and handle them gently. A cold heart is a fragile heart. Just jostling a severe hypothermia patient can trigger cardiac arrest.
All right, let's shift gears. We're leaving the environment, the snow and the sun, and we are moving into the hospital setting. We are opening the student PowerPoint now.
The emergency plus student plus PP2?
Yeah. The first slide is vivid. It's a bright red ambulance. And right next to it, in big block letters, standard precautions.
It seems almost too basic to include, doesn't it?
It does. We've been hearing wash your hands since kindergarten.
Hmm.
Why is this the lead-in for a heavy bioterrorism lecture?
Because in a high-stress situation like a bioterrorism attack or a chaotic ER shift, the basics are the very first thing to go out the window. When adrenaline spikes, people get tunnel vision. They just want to run in and save the person.
They forget the gloves. They forget the mask.
They forget the gloves. They forget the mask. And the source is placing the slide right at the gate to say, stop. There is no scenario, no matter how dramatic, where you skip this step.
It's the scene safety of the hospital.
It is. And for the exam, this is often a free point, but only if you are disciplined. You will get questions that present a really critical patient. Patient is gasping for air, turning blue. What is your first action?
One of the options will be assess airway, and another will be don gloves and PPE.
And you have to pick PPE. You cannot assess the airway if you expose yourself to a nerve agent or a biological weapon. You just become a second victim. The slide is reminding us you are the most important person in the room.
That is a really hard pill to swallow for people who go into nursing to help others.
It is. It feels selfish. But you can't help anyone if you're dead, or if you become a vector spreading the disease to 10 other patients.
Stark, but true.
Yeah.
Okay, now we're past the ambulance. We're scrubbed in. And we are facing the first monster in the deck. Anthrax.
Bacillus anthracis.
Specifically, the slide focuses on inhalational anthrax, and there's a handwritten note right at the top in orange marker that just says, "Know this."
I love that note. It's the universal student signal for the professor stomped their foot and said, this will be on the test. When you see ninth way this, you stop skimming and start memorizing.
So let's break down what we actually need to know. The slide lists initial PUL-FIS-X, which is signs and symptoms. It says flu-like, fever, cough, myalgia, fatigue.
Flu-like. That is the most dangerous phrase in triage.
Because it sounds so benign.
Because it's camouflage. Imagine the context. Bioterrorism is not usually an explosion, it is silent. A patient walks into your ER. It's October. They have a fever, a cough, and says his muscles ache. That's the myalgia. What is your first thought?
It's the flu.
Yeah.
Here's some Tylenol, go home and rest.
Exactly. 99 times out of 100, you're right. But with inhalational anthrax, if you send them home, you have likely signed his death certificate.
Whoa, that escalated fast.
Because look at the terminal SICX on the slide.
It gets dark fast. High fever, respiratory distress, DT, massive pleural effusion.
And DT means due to. Pleural effusion is fluid accumulation around the lungs. But notice the adjective, massive.
So the lungs are essentially being crushed.
They are drowning from the inside. The bacteria have moved from the lymph nodes into the mediastinum, that's the center of the chest. They are releasing toxins that cause hemorrhage and edema. The chest X-ray of an anthrax patient is terrifying. It's called a widened mediastinum. The center of the chest just looks blown out with fluid.
And the slide says, rapid progression to shock-dead toxins.
And ERT is related to. Once those toxins are in the bloodstream, your blood pressure bottoms out. You go into septic shock.
There is a statistic on the slide that really emphasizes this. When infection occurs through the lungs, the disease is nearly 100% fatal without treatment.
100%. That is not a number you see often in medicine. Usually there's a chance. With untreated inhalational anthrax, there is no chance. That is why the initial recognition, spotting the wolf in flu's clothing, is the vital nursing skill.
So how do we do that? If everyone looks like they have the flu, how do we spot the anthrax?
History, history, history. You have to ask the weird questions. Where do you work? Do you handle imported wool? Did you open any strange mail with white powder? Do you work in a lab?
You really have to play detective.
You do, because the symptoms won't tell you it's anthrax until it's too late. The history is the only clue you have in the flu-like stage.
Now, here is the part that confused me initially. I'm looking at the notes scribbled at the bottom of the slide. It says, not contagious. And then it emphasizes, not spread from person to person.
This is the aha moment. This is the logic puzzle for the exam.
It feels wrong. I'm hearing deadly bacteria, 100% fatal, bioterrorism, my brain screams, isolation, quarantine, hazmat suits.
And your brain is reacting to Hollywood, not microbiology. Anthrax is not a virus like the flu or COVID. It is a spore-forming bacterium.
Walk us through the mechanism. Why isn't it contagious?
Okay. You inhale the spores, maybe they were in a letter. They go into your lungs. Your immune system tries to eat them, but they hitch a ride to your lymph nodes. Inside your body, they hatch into active bacteria. They multiply and release toxins inside you. That is what kills you.
Okay, so I am full of bacteria.
Yes. But, and this is the key, you do not exhale spores. When you cough, you are not spraying anthrax spores into the room. You aren't shedding them from your skin. The danger was the source, like the letter or the powder, not the victim.
So if I am the nurse assigned to this patient,
You use standard precautions, the exact same ones you used for the broken leg in room 4.
I don't need a negative pressure room. I don't need an N95 just to walk in.
Not unless there is some huge amount of drainage you might touch. But for the respiratory aspect, no. You cannot catch inhalational anthrax from your patient's breath.
That is a huge exam distractor. Which patient requires a private, negative pressure room? If you pick anthrax, you get it wrong.
Correct. You have to trust the science over the fear. The test writer knows you are scared of anthrax. They are banking on you picking isolation because it feels safer, but it is clinically unnecessary.
Let's talk about the treatment then. If we catch it early before the massive effusion, what do? The slide lists a cocktail.
It lists ciprofloxacin, doxycycline, or amoxicillin.
Ciprofo was the famous one. I remember that from the 2001 mail attacks. But look at the handwritten note next to the dosage. 60-day course of
2 months.
That seems incredibly long. Usually a course of antibiotics is, what, 7 days, 10 days?
Maybe 14 for a really stubborn infection. 60 is an eternity in antibiotic time.
The slide actually poses the question. It asks, compliance an issue, WHY, patient teaching, what?
This is where the nurse moves from clinician to psychologist. Why is compliance an issue?
Well, put yourself in the patient's shoes. You take Cipro. It's a strong drug. It messes up your gut biome. You might get diarrhea, nausea, maybe your tendons hurt. That's a known side effect of fluoroquinolones.
Right. You feel crummy taking it. But more importantly, after about 5 or 6 days of treatment, how does the anthrax infection feel?
Ideally, the active bacteria are dead, so you feel cured. The fever is gone.
You feel fine. So you have a patient who feels completely healthy, taking a drug that makes them feel sick for another 54 days. What are they going to want to do?
Quit. They'll just flush the pills.
They're going to stop taking the pill, and that is the danger.
Why? If the bacteria are dead, why do we need 60 days?
Because of the spores. The antibiotics kill the active bacteria, but there might be spores still sitting in the lungs that haven't hatched yet. They can stay dormant for weeks. If you stop the Cipro at day 30, a spore could wake up at day 45.
And start the whole toxic process over again.
And you die.
So the patient teaching note on the slide is really about fear and education.
It's about the contract between you and the patient. I know you feel better. I know you hate these pills. But we are running a marathon to outlast the spores. If you stop, the spores win.
That is a powerful teaching moment. It's not just take 2 pills. It's save your own life every day for 2 months.
Exactly. It's a behavioral challenge as much as a medical one. And test questions love to ask about priority teaching. For an anthrax patient being discharged, it's not drink water. It's finish the full 60 days.
Okay, let's pivot. We've dealt with the bacteria. Now we have to deal with the virus. The other giant in this PowerPoint, smallpox.
Variovirus.
This slide is different. It's very visual. We have 2 outline drawings of a human body. One is labeled distribution of smallpox rash, and the other is distribution of chickenpox rash.
Visual diagnosis is a favorite of test writers. They love to describe a rash and have you identify it without showing you a picture.
So let's analyze the diagram. The handwritten note next to the smallpox figure says, centers where you can touch, and centrifugal rash.
Let's unpack centrifugal. Think back to physics class.
Centrifugal force. It pushes things outward, away from the center.
Exactly, like a spinning merry-go-round pushing you to the edge. Now, look at the dots on the smallpox diagram. Where are they concentrated?
They are heavy on the face. They're all over the hands and arms. They're on the feet and legs.
The extremities, the parts away from the center. Now compare that to the chickenpox or varicella diagram.
The chickenpox guy is covered on his chest and stomach, the back, the torso.
The trunk. That is the fundamental difference. Chickenpox is centripetal, it seeks the center. Smallpox is centrifugal, it seeks the limbs.
That is a fantastic mnemonic. If the question describes a rash that is densest on the palms of the hands and the soles of the feet.
You are thinking smallpox immediately. Chickenpox rarely affects the palms and soles. Smallpox loves them.
What about the rash itself? The source describes it as deep scaly, vesicular to pustular, and then crusting and scabbing, followed by pitting scars.
Pitting scars. That tells you about the depth of the damage. Chickenpox is superficial, it's itchy, it's annoying, but the lesions sit on top of the skin. Smallpox lesions are deep, they're hard, they feel like BBs under the skin.
Like little metal pellets.
Yes, and when they heal, they destroy the dermis, leaving those classic pockmarks. That is why it's called smallpox. It leaves a mark.
Now, we talked about transmission with anthrax and how it was not contagious. Smallpox.
Total opposite. Smallpox is a nightmare of contagion.
The notes here are frantic. Scribbles everywhere. One note says vaccine can't spread, which implies the vaccine itself is safe. But right next to it, Keep scab covered. It can spread.
This is a critical point for infection control. Smallpox is transmitted via the respiratory route droplets and airborne particles, but it is also transmitted via direct contact with the lesions.
And the note specifically focuses on the scab.
The scab is not just a Band-Aid. It is a biological vault. The virus stays alive inside that crust. Even when the patient is feeling better, even when the fever is gone, if they still have scabs, they are a walking biohazard.
So if a scab falls off into the bed,
That bed linen is highly infectious. If you rip the sheet off aggressively and shake it, you are aerosolizing the virus particles from the scab dust.
that is terrifying. It's like something out of a zombie movie.
It is. That's why the note says keep scab covered. It is strict containment. The patient is not clear from isolation until the very last scab has fallen off.
So, regarding isolation protocols, for anthrax, we said standard precautions were enough. For smallpox,
The source is explicit. Gloves, gown, and N95. And it specifies airborne precautions.
the N95 is the non-negotiable item here.
Absolutely. A surgical mask protects others from you. An N95 protects you from the air. Since smallpox can travel through ventilation systems or hang in the air for hours, you need that seal. You also need a negative pressure room.
To suck the air in and filter it out so it doesn't drift into the hallway.
Exactly. Total containment. This is the exact opposite of anthrax. With anthrax, the patient is safe to be around. With smallpox, the patient is a hot zone.
Let's talk treatment. For anthrax, we had our 60 days of Cipro. Do we have a magic pill for smallpox?
The source says, supportive care.
That sounds really underwhelming.
It is the reality of many viral diseases. We do not have a drug that just magically kills the smallpox virus once you're symptomatic. We support the body while it fights the war. Fluids for hydration, antipyretics for fever, pain meds.
The slide does mention antibiotics to prevent secondary infection.
And that is a huge potential trick question.
How so?
A question might ask, which medication is indicated for the treatment of the variola virus? And it will list an antibiotic. If you pick it, you are wrong.
Because antibiotics kill bacteria, not viruses.
Right. We give antibiotics in smallpox cases because the skin is full of open, deep sores. Staphylococcus and streptococcus bacteria love to invade open sores, so we use antibiotics to keep the bacteria away. But the antibiotics are doing nothing to the smallpox itself.
That is a vital distinction for the exam. You are treating the complication, not the root cause. There is a note about the vaccine, though. Vaccination effective if given within 3 days of exposure.
This is our one get-out-of-jail-free card. If you know you have been exposed, say, you were the triage nurse who took the patient's vitals before the rash appeared, you have a 72-hour window. If we vaccinate you then, we can race the virus. The vaccine might prime your immune system fast enough to prevent the disease entirely or at least make it very mild.
That's ring vaccination logic, right? Vaccinate everyone immediately around the case.
Exactly, contain the fire. But the timeline is tight. After 3 or 4 days, the vaccine likely won't help much.
Before we summarize, I have to ask about one weird scribble on the smallpox slide. It's in orange, sideways near the bottom. It looks like weed control. Or weed control.
I stared at that for a while. Weed control.
Is that a code? Is it an acronym for something medical?
Honestly, I think it is just a glimpse into the student's life. They're sitting there listening to a lecture on bioterrorism, terrified of smallpox, and suddenly they remember, oh shoot, I need to spray the dandelions in the driveway.
Or maybe they meant need control.
Yep.
Or infection control and just, stop writing.
It's possible. But I really like the weed control theory. It reminds us that these notes were written by a human being. A stressed, tired student trying to keep it all straight.
And trying to maintain their lawn.
Exactly. But for the learner listening, do not put weed control as an answer on the NCLEX. Stick to infection control.
Solid advice. So we've covered a massive amount of ground here. To bring it all together, let's do a comparative review. A sort of fight card between anthrax and smallpox, because the test will absolutely ask you to compare them.
Let's do it, side by side.
Category 1, contagiousness.
Anthrax is not contagious person to person. You use standard precautions. Smallpox is highly contagious. Airborne and contact precautions. You need a negative pressure room.
Category 2, protective equipment.
For anthrax, it's just gloves and basic hygiene. For smallpox, it's the N95 respirator, gown, gloves, eye shield, the works.
Category 3, treatment.
Anthrax treatment is antibiotics like Cipro or Doxy, and they are the cure. But you need 60 days. Smallpox is supportive care. There's no cure. Antibiotics are only for backup issues. You can use the vaccine if it's early enough.
Category 4, the key visual.
Anthrax is the flu-like drift into respiratory failure, the whitened mediastinum, Smallpox is the centrifugal rash, pustules on the palms and soles, pitting scars.
That breakdown helps so much. It clarifies exactly why the test writers love these two topics. They are perfect mirrors of each other.
They force you to switch gears. One requires aggressive medication and education, that's anthrax. The other requires aggressive isolation and protection, that's smallpox.
And wrapping it all up with the environmental emergencies.
Remember the hierarchies. For heat, prevention, then exhaustion where you're compensating, then stroke where there's failure and anhidrosis. For cold, prevention, then hypothermia, which is systemic and life-threatening, then frostbite, which is local and threatens the limb.
The overarching theme of Chapter 11 really just seems to be safety first.
Assessment and safety. Whether it's telling a construction worker to drink water or putting on an N95 before entering a smallpox room, the nurse's job is to stop the damage from spreading.
And to recognize the threat. To see the dry skin and think stroke. To see the palm rash and think smallpox. To see the flu in a postal worker and think anthrax.
That detective work saves lives. It's about not being on autopilot.
You know, thinking about that weed control note again,
Yeah?
it actually sparks a pretty interesting thought about how we process all this. In an emergency, whether it's a heat stroke patient coding or a bioterrorism threat, there is so much noise, so much chaotic information flooding your brain.
Oh, absolutely. The monitors are beeping, family members are yelling, the patient is confused.
Right. And maybe the real skill of a great nurse isn't just knowing the facts, but knowing how to filter out the dandelions, the irrelevant noise, and focus entirely on the one thing that will save the patient in that exact second.
That is a profound way to look at it. You have to weed out the distractions to see the widened mediastinum or the core body temperature.
So to the learner listening, visualize these patients. Don't just memorize the words, see the rash, feel the dry skin, imagine the conversation about the 60-day pill regimen. Filter out the noise.
If you can visualize it, you can answer the question.
We are going to leave it there. Keep studying, keep decoding those messy notes, and remember, safety first. Always.
Good luck out there.
Thanks for diving in with us. We'll catch you on the next one.